you. Thank you all for being here. Dr. Eberlin, I've long had an interest. I'm not sure I fully understand it from a scientific perspective, but I have long had an interest in genomics, genetic medicine, and the impact, particularly on cancer. It's fascinated in your testimony about Dr. Ortman. Am I pronouncing it the right way? This particular case of, I assume he's either a practitioner, a researcher, or both, who himself was. And they were able to identify not just a specific characteristic of the genetic makeup of his cancer, but a off-label drug for kidney disease that were able to treat it. So the promise of this is extraordinary, and it leads to the notion that cancer isn't really one disease. It is millions and millions of variations of it and very individual specific. So there's a tremendous amount of promise, and you also outlined how that can make a difference in the treatment of breast cancer in your own practice, where about only 20% of the people impacted by breast cancer would need chemotherapy in addition to radiation and surgery. And imagine if we could find who that 20% were, not just the impact on their lifestyle and the improvements in their care, but on costs, both to the healthcare system and to their lives. So this is very promising. My question is, are we applying the same level of intensity and focus on an understanding of genomics and genetic medicine in the pediatric realm? Are we making the same progress on the pediatric realm as we are in the adult population? And if anyone else has a comment on that, I'd love to hear about it as well.
Actually, we are. Washington University, along with St. Jude, actually mapped most of the genetic mutations associated with pediatric tumors. And the collaboration between St. Louis Children's Hospital, Washington University Siteman, as well as St. Jude's Research Institute have created a pattern looking at the pathways for the cause as well as spread of those tumors, and have identified a number of novel targeted treatments. So again, it's actually been one of the more rewarding aspects of areas of genomics. It's been particularly advantageous in the pediatric population, and I think there's a plan for more investment both at St. Louis Children's and Siteman Cancer Center, as well as at St. Jude's.
Sure, I think the genomics has really revolutionized how we can look at pediatric cancers. And at St. Jude, the ability to go from bench to bedside, making those discoveries, and then doing targeted medicine for pediatric cancers has really been amazing what's happened in the last 7 years since I've been there. It's really changing how we treat pediatric cancers.
My understanding is there's outside, just in the general realm of cancer, there is a lot of collaboration nationally on tumor banks. I know there's, for example, one at the Moffitt Center in the Tampa Bay region. There's a lot of, everyone is capable. Is that information widely shared across the research?
Yes, actually, there has been a lot of additional sharing among the institutions who, like Washington University and Siteman, have particular expertise in the genomic area. That we have shared not only the genomic information that's freely available to other institutions, but also with de-identified clinical information that is linked to that genomic information. And so these create very powerful databases that one can compare an individual patient with other patients with a similar type of fingerprint genomically, and then develop an individualized treatment.
So then the question I have is, and this is my final question given the time, I'm just struggling to understand, how is the FDA process going to work if this medicine is so tailored at the individual level that there may be some, are the tweaks and the changes that would be required in treatments from patient to patient, does that apply? Do you foresee a point where the medicine and the treatments become so specialized and so specific and so different one from the other that it would require a separate FDA approval process that could complicate and slow it down? I mean, I don't know if I'm describing it the right way, but if there are 1,000 different ways to treat the same cancer and the medicines have 1,000 different formulations as a result of that, if they're significant enough, how does the FDA process account for that as we move forward?
Well, the FDA is actually expediting some of these personalized treatments. And again, to use Lucas Wortman's example, this was a drug that was FDA approved, but it was approved for the treatment of kidney cancer. In the case of Lucas, we identified that he had a specific point mutation that was the cause of his recurrent leukemia, not kidney cancer, but predicted that it would have response to this very targeted therapy, which blocked the downstream impact of the gene mutation. And that's exactly what happened. And so I think it's a little bit of a change in paradigm for the FDA that some of these treatments will be applicable to a different patient, but the treatment will have been similar and the side effects, et cetera, would be similar.
And this is just quick, is that the only time, is that the first time that that drug had been used off-label for that purpose?
It has been the first time that it was used for a leukemia patient, yes, sir.
And so was that, how does that now, is that now replicated? Has it been used again by others? How is that documented? How does that, does that count as a clinical trial? I mean, how does that work in terms of
It would be as long as a patient has had whole genome sequencing and that specific mutation were in the patient. Then you would be able to use that drug off-label.
And why I ask that, Mr. Chairman, is because I can foresee where some insurers will push back on, I'm not going to approve a drug that's for kidney. He doesn't have a kidney problem. He has a leukemia issue. And so that's why it's so important to document.
Well, we've done exactly the same thing, taking chemotherapy that is very effective in colorectal cancer, and we identified that in about 20% of non-small cell lung cancer, that the drug for colorectal cancer is actually very impactful. And so again, but only through genomics and comparing the genes and the sequences in the lung cancer patient and the colorectal cancer patient, that we applied the colorectal drug to the lung cancer patient.